So let's talk about navigating a positive induction experience. Choosing induction, if it is right for you, is absolutely a valid answer. But there are a couple of questions that I want you to ask yourself and your care provider before you agree to one. Step number one is looking at the importance of a full-term pregnancy. Some of the benefits that happen when we have a full-term pregnancy. Our body is not only better set up for birthing, we have that nice cocktail of hormones that is released both from the placenta and our baby's lungs, saying they are ready for the outside world, nudging us closer to having that physiological birth that so many of us strive for. Our baby is also laying down that beautiful brown fat in those last few days and weeks that helps them to regulate their temperature and their blood sugar levels. Our body is also much more set up in a way that it sends lovely messages, and all those beautiful neurotransmitters are joining together to help our baby to have those newborn reflexes firing off for things like nursing, for regulating their suck, swallow, breathe sequence. And so as a result, those babies who have a full-term pregnancy are much more able to navigate the world outside of the womb. They feed better, they have better management over their temperature, their blood sugar levels. They're much better able to navigate things like the suck, swallow, breathe sequence. And they're much more likely to have a nice alert wake window so that they can nurse efficiently. So it's worthwhile pondering about those things. The next thing then is pondering if an induction is in the best interests of you and your baby. There are very few medical reasons whereby induction is totally necessary. And so it's really important that we have open, honest conversations with our obstetricians, looking at the research, checking in with our doula, and looking at the best practice. It would be naive of us to believe that best evidence practice is being applied to all of our hospitals today. We know that it takes about 17 years for that research to actually enter the hospital practices. And so a lot of research on our parts can be required to make sure that we are getting to that place whereby our bodies and our babies are getting the best support that it needs, and choosing induction for reasons that are not supportive for our own well-being is sort of like fast-tracking ourselves into the birth that maybe isn't part of our plan. That is not to say that you can't have a positive induction, but I think going in with our eyes wide open and understanding the pros and the cons and whereby those can come into play is hugely, hugely important. Let's look at the next part of this question. What exactly does an induction entail? So we know how our body unfolds physiologically and how labor begins. When we are inducing labor, we are working with synthetic hormones that are trying to nudge our body to begin the labor process. There are several different ways in which induction can take place. You can either have insertion of a pessary, which is like a very tiny little tampon that contains prostaglandins, which we know soften and ripen the cervix. So that is popped up inside the cervix for 24 hours and then can be removed at any point if those contractions begin. Typically speaking, that is step one in an induction process. Another alternative step one is a prostin gel, which similarly is applied via an insertion device to the cervix, whereby that gel then sits there and helps to ripen and soften the cervix with those synthetic prostaglandins. So an ARM is another alternative for bringing the induction process along. If your body has already done a little bit of work and the cervix is already open a little bit or soft enough that they can insert an amni hook alongside their fingers on vaginal examination, they can then make that little pinprick hole and release the bag of waters around your baby. Typically speaking, this then means that our baby's head can apply better to the cervix, which then brings back that loop of hormones required for contractions to begin. While we know that that bag of waters is really important, this can be a lovely way of avoiding the synthetic hormones. However, when we have that bag of waters intact, it cushions our contractions for both us and baby, and anything being inserted vaginally, including the release of that nice double-layered membrane, can mean an increased risk of us having an ascending infection. So when we don't have that lovely double-layered membrane in place, this means we can increase our risk of ascending infection. If those don't work, we can then be nudged to the next stage of our induction process, whether that is going across to the labor ward or being allowed to give some time. We can be administered through an IV line a synthetic version of oxytocin. As with everything, this has its pros and cons as well, but through this IV line, we have this bag that is filled with the synthetic oxytocin and water, and that is steadily administered and dripped through and titrated at different rates depending on how we are contracting. The difficulty with this is that we don't get that lovely feedback of the endorphins, our natural pain relievers. So typically speaking, synthetic oxytocin is a lot more intense than it is for our body to deal with our natural contractions. The Foley catheter, which is inserted inside where the cervix is and steadily dilated and grows bigger to help the cervix to not only soften it but also open, is another option. Yes, it's medication free, but again, without that natural cascade of hormones that we have, and perhaps a baby who is not well applied to the cervix. As with all inductions, it can be a very long process. When we're preparing for induction, I really urge you to prepare for at least 3 days. This is 3 days in the hospital. Maybe you have to go through each of these steps, from a Propez or Prostin to then possibly an ARM, to then possibly having synthetic oxytocin on day 3, but you're going to be doing this on not much sleep. So bring in your noise-cancelling headphones, your eye mask, and your pillow from home to make sure that you can be as comfortable as possible. Setting your environment up is also going to be hugely important so that you can feel comfortable and really bring that home from home atmosphere. When we talk about induction, I can't bring up the topic without nudging you to look at the statistics, the facts. What happens when we consider induction? How does that look in terms of the possibilities for us to still have a physiological delivery, and how does that set us up for success or not? According to a huge several-year study in 2001, if this is your first baby, by accepting induction, you are only having a 42% chance of going on to have a spontaneous vaginal delivery. So this is a delivery not involving forceps, a kiwi or a suction cup delivery, or cesarean. Whereas if you go into spontaneous labor, not involving induction, you have a 62% chance of having that physiological vaginal birth. Your chances of a cesarean then are 29.39% versus 13.8% if you go into spontaneous labor. That's quite a big difference. Use of an epidural is a whopping 71% for those of you who are induced versus 41% of those of you who've had a spontaneous onset of labor. Looking at episiotomy then, it's 42% of you who are induced who are likely to have an episiotomy versus only 30% of you, which not so much of a difference there, of you who have allowed spontaneous onset of labor. We also know that by accepting induction, we are increasing our risk of hemorrhage, so that is a bleed post-birth, with 1.5% of you experiencing a postpartum hemorrhage after agreeing to induction. So it's really important that we go into induction with our eyes wide open, in knowing these risks, in knowing that once we agree to induction, we are immediately transferred from low risk to high risk category. And we're also taking that first step in us going down that route of that cascade of interventions that can come with an induction. When we are having an induction, we are more likely to have an epidural. When we have an epidural, we're more likely to run into troubles with our blood pressure, with baby's heart rate. We require bladder emptying with a catheter. We require IV fluids. We are more likely to have tearing or an instrumental delivery. Lots of these various different things can come into play. And so choosing to meet your baby a little bit early is simply not a good enough reason. We want to be looking at what is medically necessary. We want to come back to that understanding and that knowledge that very few of our babies are actually born on their due date or guess date, and varying from hospital to hospital, from country to country. We know that a full-term pregnancy, according to the World Health Organization even, is considered anything up to 42 weeks of pregnancy. I've experienced supporting women even into their 43rd week of pregnancy. And so it is very normal. If you decide to say no to an induction, no is a full sentence. You don't necessarily have to give any more detail as to why you don't want to accept an induction. However, you might feel more comfortable if your doctor is saying that they feel less comfortable supporting you in agreeing to a little more monitoring. This might mean going in one day for an ultrasound, the following day for monitoring of baby's heart rate via CTG, and then alternating those for every day, maybe towards the end of your pregnancy. But once your baby is doing well, their movements are going well, and you have great flow of that lovely nutrient-rich oxygenated blood from placenta to baby, there is no medical reason for you to end your pregnancy early. So when you are navigating an induction, I want you to do it with your eyes wide open. I want you to have a positive induction experience. So that means having all of that knowledge so that you can pull the parts that feel right for you, so that you can then have an empowering induction experience. Asking those questions. Is this right for me? How is this going to look? What sort of an impact is this going to have on my birth experience? How is this going to set me up for a physiological birth, if that is what you are striving for? And knowing all of your options so that you can create preferences related to that induction experience.